So Joe, how do we start managing these patients?
I have no idea.
No idea? None at all?
Okay, so again, we alluded to initially ABCDE. This is the staple management that we're going to start off with. Thinking about the ABD approach. The ABC.
Joe Francis special ABD.
Should we cut that out?
Circulation's not important enough for Joe, please.
Should we cut that out just for my registration?
No,
So thinking about ABCD approach to this assessment and things that we're kind of really looking at. These patients at airway, they're probably going to need oxygen therapy if they're looking shocked. Thinking about what I missed out in terms of circulation, 2 wide bore cannulas. Fluid-wise, for addressing hypotension, really we want to be limiting the use of crystalloids, limiting our use of Hartmann's and or normal saline, which of course do not replace any of the important things that we need to replace, so hemoglobin, clotting factors, etc., and can cause a dilutional coagulopathy. So we want to be replacing blood with blood as soon as possible. If there is a delay, then judicious use of 250 ml boluses of fluids is probably the best way to go whilst rapidly trying to seek those blood products. Mm-hmm. Considering, again, when you're seeking those blood products, whether actually you need to trigger a major hemorrhage protocol. And alongside that, in the last few years, we've probably all heard of the rise of tranexamic acid. And
sounds like a film.
Yeah.
The rise of tranexamic acid.
Well,
Transformers Part 7, Rise of tranexamic acid.
We're about to go off and get copyright for that film right now, before the Crash 2 collaborators come in and grab it from us, because of course they listen to this podcast. So, in terms of tranexamic acid, there have been a couple of trials that have come out, specifically the HALT-IT trial, which is looking into upper GI bleeds and tranexamic acid. It's currently an unlicensed use of tranexamic acid. However, it's got quite a good safety profile. We're seeing it used in patients with major trauma. We're seeing it used in patients who have had massive maternal bleeding, specifically postpartum hemorrhage after the woman trial. And now we're seeing it come into upper GI bleeds. And basically people who are bleeding are now starting to get tranexamic acid. So whilst it's an off-license utilisation of tranexamic acid at the minute, it's not particularly harmful and may be beneficial. However, it'd be good to look at trust guidelines and kind of discussing with seniors before having a think about that. It has been shown in bleeding patients to reduce transfusion needs and to have a mortality/morbidity benefit. So it's definitely something that needs to be in your armamentarium. What else can we do for these patients, Matt?
Well, one of the key features which we don't always think of, because you get these patients who are bleeding extensively in resus, messy bleeds that we talked about earlier. Actually, antibiotics should be a lot higher on our priority list than they probably are, because we don't really think too much about them. And it's not because we think this patient has an infection, it's because actually the majority of patients who don't die from their bleed, who don't bleed out, die from infection over the next couple of days. And actually, obviously, if you've got lots of blood everywhere and you're unwell, then you're at higher risk of developing an infection, developing sepsis. And so actually getting antibiotics on board early is actually really good for these patients and has proven to increase survival. So actually we should probably consider antibiotics, alongside our hemorrhage control and our major trauma packs. One of the things that often gets difficult in practice is the use of IV PPIs, IV pantoprazole or omeprazole or whatever it is that you like to use. It's something that's sort of typically been taught that's how we manage them, and it is still used in practice. There's very limited evidence about them actually working, and it comes down to a sort of a risk versus benefit ratio. There's no real risk to it. There's probably not a great deal of benefit, but a lot of the gastroenterologists still like to give it, even though there's not a lot of evidence. But again, that's one of those things we sort of consider quite highly. One of my personal things is if they've got pain, then I often give it routinely, assuming it's from sort of an inflammatory type response to a gastritis or an esophagitis. I think it's probably beneficial there. But as I say, the evidence there is limited.
I think it's interesting, isn't it? Because theoretically, thinking about it, those PPIs actually kind of block those cells for anything up to 24 hours, don't they? And so actually, you would theoretically think just as many things in medicine where you would theoretically think and are subsequently proven wrong, but you would theoretically think that it then also reduces the risk of re-bleed, perhaps, because you're reducing that acid load in the stomach. But it's interesting to see that something so clearly theoretically obvious doesn't actually prove out in practice. So it's always something to actually consider: why am I giving it, and what is the evidence for this?
Definitely. Another drug that we see quite commonly used, certainly in our sims, actually, I think our fifth year, certainly this year, been really good at saying the word terlipressin. Terlipressin isn't for all upper GI bleeds, and that needs to be made clear. Again, a lot of our students think it is. It's not. It's for varicose bleeds only. It works by constricting the splanchnic vessels, which help reduce bleeding and affect the portal hypertension there. So you have to have the portal hypertension for it to be effective. But yeah, terlipressin is certainly something to consider if you're worried about varices or if you have evidence of previous varices. Otherwise, in terms of that sort of moving away from medication, there's balloon tamponading, which is quite dramatic. If you put the saying, I can't say the word, but the saying stuck and Blakemore tube, I can't say it, but balloon tamponading is a lot easier to say. You essentially put it's basically an NG tube down into the stomach, and then you inflate it, and it's like a large sort of sausage thing, really. It just tamponades the vessels that are bleeding. Those are for your really sick, sort of peri-arrest, if not arrested patients. The success of it is quite low, but that's because you're using it on patients who are that unwell that they're probably not going to survive anyway. But that's something to consider. You might see that used for these particularly unwell patients. And as we talked about earlier, endoscopy is both an investigation and a management. We use the Glasgow Blatchford score, or sometimes called GBS. That's the most commonly used, the most effective scoring system that we have for upper GI bleeds. There is the Rockwell score that you might sometimes see used in practice, but Glasgow Blatchford is preferred. And this is quite a simple score. I won't tell you what it is because it's easy just to pop into Google, or other search engines are available. And it just helps identify which patients are high risk and which patients should have endoscopy, and equally which patients are low risk and can be discharged with appropriate follow-up. So in terms of endoscopy, obviously you're putting an endoscope down into the stomach. As I said earlier, there's going to be a bit of sedation, if not a GA. Here you're looking for things that are bleeding. So going back to our causes, is it a varice or bleed? Is it inflammation? Is it malignancy or whatever? You might clip certain lesions. You might use band ligation if there are varices are present, and you can inject things like fibrin or thrombin, sometimes with adrenaline, just to help clot off those bleeding areas. If endoscopy fails, or if there's another bleed post the initial endoscopy, then we might do another endoscopy. We might ask our interventional radiologists or our surgeons to have a look and to see what management they can offer. But it depends on the lesion and the patient and whether they're a candidate for these sort of interventions. And that's what I was mentioning earlier about if the endoscopy fails or doesn't identify the appropriate lesion, then those patients might go on to have a CT abdomen or a CT angio looking for the responsible lesion, and that's when you're probably going to include or involve these surgeons and interventional radiologists in your management. The other thing that you will often see in practice, or maybe not often, but you will hear about and read about is a thing called TIPS, which is a transjugular intrahepatic portosystemic shunt.
Could you just say that one more time for us?
No. And basically, this is where you get sort of a stent and a shunt placed under interventional radiology, which goes via the portal vein to the portal vein to the hepatic vein, and that reduces the portal hypertension and reduces the risk of rebleeding. And we generally use that acutely if patients are bleeding and it can't be controlled by band ligation through the endoscopy. So those are your acute things. In terms of ongoing management, Joe, what sort of things do we need to think about?
In terms of long-term management, we really need to go back to our risk factors and think about how we can reduce that risk. So I guess the first thing is to invent some sort of time machine that could reduce the age of all of our... No, sorry. So, on a more serious note, thinking about one of the most common causes of our upper GI bleeds being peptic ulcer disease. Now, this used to be a very, very prevalent and in fact untreatable disease until the discovery of Helicobacter pylori and eradication therapies for this. And Helicobacter pylori is, it's quite a fascinating bacteria and disease in its ability to kind of break down that internal stomach environment and protective layer to get to the mucosa. Really, we need to be thinking, if there's peptic ulcer disease present, about Helicobacter pylori investigation and eradication, which will usually involve something like amoxicillin, clarithromycin, and a PPI regimen, and then obviously changing that up dependent on penicillin allergies and/or dependent on local microbiology, minimum inhibitory concentration stuff.
Oh, wow.
Clearly, if these patients are at risk because of quite significant alcohol dependence issues and/or intake issues, then recommending and trying alcohol abstinence and/or reduction regimens, whether that's through in kind of primary care, through kind of psychotherapy, through rehabilitation and things, is a really, really good public health message to get out there. And then in general, thinking about acid suppression therapy, so whether that is through products like histamine receptor antagonists like ranitidine, or thinking about proton pump inhibitors again for kind of chronic therapy, so whether that's your omeprazole, lansoprazole. These are the sort of things that we need to be thinking about moving forward in terms of long-term therapy for reducing the risk of rebleeding in these patients. And of course, giving good information about medications that they may be taking chronically or maybe getting over the counter that may increase their risk of upper GI bleed. So what we talked about before in terms of non-steroidal anti-inflammatories or actually steroids themselves.
So that's pretty much all we wanted to talk about really with this podcast. So we've been over the overview and the causes. As I said, the most common causes are peptic ulcer and esophageal or gastric varices. Features, typically we're looking at hematemesis, coffee ground vomits and melena. Investigations, looking at your blood tests. Management-wise, ABC approach, 2 cannulas, blood resus, and actually antibiotics, think about high priority. And then using your Glasgow-Gratchford score to decide whether the patient should go for endoscopy. And then long-term management that we were talking about. Joe, have you got a witty sign-off?
I could try and make one off the top of my head, guys. So don't get your stomach in a knot thinking about this podcast or listening to it rather. And we'll catch you next time.
I can't believe that you didn't. You didn't create one earlier.
Oh yeah, you did. Okay, yours is better. All right, thanks, guys.